So I think we now have a very good understanding of what CRSwNP is, the underlying inflammatory mechanisms, and the differing ways that people can present. And it's clear that clinicians do have a choice of therapy. But it's also clear that there are a multiplicity of factors to take into account before deciding the treatment pathway. Can I just go back to you, Daisy? How much was discussed with you before you started your treatment about the various options? Was it just given to you? You were told this is what's going to happen, or were you taken through each of those therapies and taught about the upsides and the downsides?
No, I was very much involved. I'm going to tell you this. After my second surgery, there was a period that the nasal polyp syndrome wasn't good, and I went back to the specialist, but there went something wrong with the agenda, and I was with an assistant. And the lady did what she had to do. She looked at my situation, and afterwards she told me, yeah, when this is not going to be better, we have to do another surgery. But I was so afraid, and I was so there was so much panic in my head that I didn't want to do a third surgery. So I talked to my specialist, and we find out another treatment to avoid the third surgery.
Okay, so you were very much involved. What about you, Natasha?
Well, I'm in a better place as 4 years ago because one of my worst problems was coughing all the time, and that was really helped by the biologics. But I do worry sometimes about side effects because I do have some, and I'm like higher blood pressure, I have heart problems, I suffer from acid reflux, but I don't know if they are a consequence of the medication or not.
Okay. Joseph, Professor Han, just in terms of surgery and revision surgery, what do you look for in terms of indications when you move to that treatment option?
So, when I think about doing revision sinus surgery, there are probably 4 things I think about. Is the medical treatment going to work again? Is the initial sinus surgery complete? The third one is there a complication or an issue from the prior surgery that leads to something that's not going to get better with medicine? And the last one is patient severity. If the patient's symptoms are severe, I'll talk to the patient and discuss the shared decision-making process that we discussed earlier. And if the patient is really inclined to doing surgery versus another medical treatment, I'd do surgery again.
Right. And Professor Fockins, anything to add on that? Would you agree with those 4 things that you consider?
I do absolutely agree. I think it's very important to be sure, especially in revision surgery, what are you going to do differently from the first time? And if you are another surgeon than the first surgeon, then you usually know what to do, what goals you want to achieve. But especially if you revise your own surgery, I think it's very important to discuss with the patient, but also to consider yourself. What is exactly I'm going to do differently next time to have a better situation? And if you can't answer that question, if you just redo what you did before, I think that is a very good reason to think twice before you do revision surgery, and you might better choose another option.
That's a really important point. Let me bring in Joachim now, Professor Mullol. When we move to biologics, what are your considerations before you put a patient on biologics?
Well, the first option that we have in a patient with biologic is that we have to have a severe patient that has received the appropriate treatment, either medical and surgical, but remains uncontrolled no matter of the treatment. And also, at least it has received 1 surgery. That is what the guidelines, the consensus agree on that. Then there are several factors, several criteria that Professor Fockins has talked before, some of them, but practically we have 5 of them. One is the presence or the evidence of type 2 inflammation, mainly marked in blood eosinophilia or nasal eosinophilia or eosinophilia. Also, we have the need of oral corticosteroids. That is an important burden for the patients. Also, an important impact on the sense of smell and in quality of life. And finally, comorbidities. Comorbidities that usually need treatment, inhaled treatment. If you have 3 of these 5 criteria, we agree in EPOS and EUFOREA that there is a proper indication of a biological in a patient that has received at least one surgery, one appropriate surgery.
Okay, and Dr. Sharkar, would you like to add anything else into that about biologics and what you look for?
I think one factor is very important, and that is systemic disease. The more systemic the presence of symptoms in the patients are, the more likely it is that I will recommend a biologic. So if I have the evidence that my surgery can improve the situation in the patient, and if I have the impression that there is a good correlate that we can target by surgery, then I will also discuss the benefits of surgery. If the patient suffers from several type 2 comorbidities and has strong signs of systemic disease, of systemic inflammation, then I will probably prefer a biological treatment. And it is the criteria that Professor Muyol has just mentioned. And it is this thought that the presence of, for instance, eosinophilia, of total IgE, of comorbid type 2 disease, these are all signs of systemic disease. And this tips the balance.
And Daisy, bringing you in here, when surgery was talked about, what was your view of surgery when that was first given to you?
When it was first given to me, well, the consequences I had, and I was suffering so much that I agreed with the first surgery, because I was so hopeful that the problem would be solved afterwards.
And what about you, Natasha, in terms of that first mention of surgery? What were your thoughts?
Well, they didn't really give me a choice, because the only thing they said was that I had more than 100 polyps on my nose and that they had to be removed to get me better. So the first surgery wasn't really a choice.
And so then, just in terms of moving on then, Natasha, when they finally said to you, right, we're going to start you on biologics, what did you think about that?
I'm in a better place than 4 years ago, and the only thing that is not that hasn't been better is the smelling. So I hope with the 4th and last medication that will help me.
So just in terms, when they started talking about biologics to you, you went away, you read the side effects and everything. Were you frightened before you started using biologics?
Yes, I was.
Interesting.
Yeah.
What about you, Daisy?
I was more afraid when they told me they had to do a second surgery.
Right. So that frightened you more than the idea of biologics.
More. Yeah, indeed.
Okay, can I just sort of wrap this up, actually, coming back to you, Joachim, to Professor Muyol. In terms of biologics, in your view, what sort of patients tend to benefit the most and who benefits the least? Well,
this is quite biased by the kind of patients that we have to treat. I mean, you have to understand, and sometimes we are in the position that we can only treat severe uncontrolled patients, because the indication, we cannot administer these drugs to early stages or to moderate stages that potentially could be or have more efficacy. We have to give to these patients. I mean, as I think, like Dr. Falklands and Dr. Sharkar has said before, I mean, when there is a big amount of severity around about the size of polyposis, about the inflammation in the blood or in the nose, the association with comorbidities, the burden. And the burden of the disease is the massive use of oral steroids, not the intranasal steroids, these are quite safe and they should be used in all steps of the treatment. But oral steroids create an important burden and repetitive surgeries. When all of this joins in a mixture, usually in a lot of patients, is the moment that if you have the possibility of give these drugs because they are reimbursed, to have an indication of biologics for these patients.
And Witzke, Professor Fockins, it was just really fascinating listening to Daisy and Natasha about their feelings about surgery and worry about surgery, and indeed worry about biologics, the side effects of this. I often think that maybe sometimes clinicians don't take into account how the patients feel, their trepidation about what they're about to go through.
Yes, I agree. That's a big issue. We know that what we say in the outpatient clinic to a patient, that 90% will not be remembered because you're tense and patient is. So I really always like my patients to record what I tell them. And also very good to have someone with you if you go to a consultation to hear what is actually said. I think it's really important to emphasize that biologics are, as far as we now know, and for some of these biologics we have 20 years of experience, are very safe treatments. They do not lead to hypertension. They do not lead to heart disease. They do not lead to cancer. So I think that's very important to emphasize to patients. That, of course, it's relatively new treatment, that some are on the market now for 4 or 5 years, and we can't predict anything, but that there, until now, is absolutely no indication that these biologics have severe side effects. For surgery, we know that the more often a revision is performed, the dangers of the surgery increase. And that's something we have to discuss with our patients. If there is more scar tissue, if there has been a number of earlier surgeries, surgery becomes more dangerous. And it's always important that if you do a revision of a revision of a revision, that is done by very experienced surgeons who know what to do in a situation like that.
And Dr. Sharker, Adam, anything that you'd like to add to what Witzke, Professor Fockins has just said?
I can fully confirm that it is very difficult for the patients to basically get everything from one consultation. For sure, there are very different psychological profiles in our patients, but one is very common when you work in a tertiary referral center or university hospital, that patients have underwent several treatments and they are not happy with the result in chronic diseases. In particular, right now we are speaking about chronic rhinosinusitis with nasal polyps. And that is actually what has changed a little bit in the last 4 years, that patients, they inform themselves, they read. They read also for sure about potential side effects, and the consultation that I have observed in the last years, they have changed in a way that there is more dialogue about the available options. But for sure, it is difficult because this is our daily business. We do that 20 times a day, and our patients hear it perhaps for the first or second time in their life, and it's difficult for them also to emotionally handle and cope with the situation. So I think it is very important that you give the opportunity to come back perhaps for a second consultation. That is not always possible, and for sure we have to also to treat all the numbers of patients that are on the waiting list. I mean, we are perhaps more comfortable with this in Germany. We don't have usually waiting lists, not yet. but in a way, I see this kind of tension. I think with regards to the safety profile, Professor Fockens-Wietzke made a fantastic and important point. By now, the real-world evidence data and also the clinical studies from the last 20 years for omalizumab, for the last, let's say, 8 to 9 years for dupilumab, and 8 years for mepolizumab, and for other biologics as well, like benralizumab, that are not used in our field, so they have been explored. And the upcoming new biologics like tezepelumab, they have really good safety profiles. They may have differences among the different antibodies, but overall, if you think about the efficacy of these treatments, they are remarkably safe. And it's really fundamental breakthrough for our patients, not for everyone. And there is still a lot of patients who are going to benefit from surgery. But I think we can today, with much more credibility, advise our patients which treatment they have to choose or may choose.
Such strong points from all of you. Thank you very much indeed. Let me just pause you for a moment. So, I mean, clearly what's transpired from that conversation is clearly it's a complicated picture. There are lots of factors that we need to take into account before we decide on a treatment pathway.